So we are in a very tight schedule. We try to put as much as we can. So one thing that I failed to say in my introduction is that our center is very efficient. So I will serve today both as the greeter, chairperson, and speaker later on. So during the... So the first speaker for the second session is Doron Behar. He's coming from Gene by Gene Carmel Medical Center. Doron, please.
היי, כמעט צהריים טובים, אחרי הסשן הזה ארוחת צהריים. So first, please allow me to thank the organizer for the opportunity to come here and present our work. We will be discussing today the option of merging a comprehensive preconception carrier screening panel and chromosomal microarray analysis, which was already mentioned in the previous talks. I should disclaim and say that this talk is going to present work that was done in collaboration with a commercial company, Gene by Gene. And with this, we can start with the presentation. So a very important thing to say is that we are all hearing in the last years more and more often the terms personalized, genomic, precision medicine. And there is even a journal of precision medicine, and there is many discussion about it in the New England Journal of Medicine, and even the initiative being presented by President Obama. And if you will read it, you will see that it is speaking about curing diseases like cancer and diabetes. So many times people are stopping me and are asking me, if I'm going to run my exome or my genome, will you be able to tell me how many times I should practice per week, or what should I eat, so I will not have diabetes when I'm 65? That's the concept of many people in the public about precision medicine. And that might be true one day, but this is certainly not the case today. And the case today is that by using our exome and our genome, we can primarily identify risks. Risks for Mendelian disorders, of autosomal recessive Mendelian disorders, risks for early onset neurological diseases, risk for some cancers, like the famous BRCA1 and BRCA2 genes. But we are speaking about identifying risks of defined diseases, and less today about the complex trait diseases and so on. So we are going to focus today on the preconception prenatal progress that have occurred in the last decade. And when we say preconception, for the sake of simplicity, that will comprise both the period before the pregnancy and the prenatal period, which is during the pregnancy. Maybe one of the most important revolutions was the chromosomal microarray analysis that was mentioned here, the digital karyotype, so to say, which became so important and in a day-to-day use that there are even lectures that one can find in the web, over the web, by key opinion leaders that is saying the case for offering all-woman amniocentesis and chromosomal microarray analysis. That is naturally not something that is currently recommended, but it is being driven from the fact that we know that by chromosomal microarray analysis, we can identify up to 1 in 100 or 150 healthy pregnancy in young women. We can find a significant microdeletion or microduplication syndrome. The second one is maybe the opposite one, is the non-invasive prenatal testing, which is this technology that was spreading over the last 5-6 years, that you can check for a certain copy number differences, primarily trisomy 21, 18, 13. You can check from maternal blood during very early stages of the pregnancy. You can actually identify a risk for Down syndrome. So quite the opposite from chromosomal microarray analysis. And the next revolution, which is currently being addressed, there was only recently a very nice paper in JAMA about it, is the expanded carrier screening. which is actually saying, so far we have been limited to a few mutations that we are checking, but the knowledge of the mutations is ever growing, and the methods allows us to screen more and more mutation at the preconception stage, and maybe we should offer it. So the reason that Israel is particularly abundant with rare autosomal diseases, it was already mentioned. First is the bottleneck effect, or the founder effect, that is something which is common to many Jewish diseases. For example, the estimate that the contemporary Ashkenazi Jewish community, in which we know that there is a large number of Ashkenazi diseases, was founded by 300 people, roughly 1,500 years ago. The second mechanism, demographic mechanism, is naturally consanguinity, which is often being practiced among Arab, Druze, and Bedouins. So the current model is that we want to screen only for severe diseases, so Tay-Sachs, Bloom, cystic fibrosis, etc. The frequency that was set is an arbitrary one, is 1 to 15,000 live births, which represent roughly a carrier rate of 1 in 60. The possibility to detect over 90% of the carriers. It is targeted, which means that we are only going to check a few mutations, the mutations that we are listing. It is sequential. First, one of the couple is doing it, and then the spouse. And it mandates medical geneticists and informed consent before doing it, of course. Now, we might want to question this. We might want to ask, why was the bar of 1 to 15,000 set? Maybe it is time to check mutations that are in a carrier rate of 1 to 200 in the population. Indeed, it's going to be very, very few patients that we might prevent in the population. But still, if the genomic era and the genomic technologies allow us to do it, why not? If you're going to look over the internet presentation of Professor Yoaz Lotogora, who is, of course, well known in all his huge work for this purpose in Israel, you can see that the end of the presentation, and I just copied it from this, is noting the future, targeted program or universal program, sequential or couple screening. So, indeed we can see that there are already many, but let's say many companies that are starting to offer an expanded preconception screening, like Counsel, Gusta Genomics, like Gene by Gene, like Mount Sinai, and so on and so on. So that is very much available, and we want to see if we can use it and harness it into a population program that can prevent more diseases. Now, the major issue here to say is that before we speak about prevention, because here we are in a conference of the BCDD, so we are not speaking about treating the diseases, but we are speaking about preventing them. But when we are saying preventing diseases, I would like to break the link. Prevent the disease does not necessarily mean that one wants to recommend an abortion. It might also be early treatment. It might also be a relief of stress of parents, and so on. So preconception screening is not necessarily done. It is certainly very much done to suggest informed reproductive decisions, but it might also help in starting early treatment and so on. So what are the potential advantages of expanded panel in Israel? First, it can allow screening campaigns that are compatible with the genomic era. It can really allow to include all the important mutations that we have heard about even today in a broader and broader panel. Second, there are changing demographies. It is a bit hard to know currently the level of 4 grandparents that all are Ashkenazi. It is sometimes hard to find residencies as a sign for which mutation should be checked for the given couple, primarily for our populations. There are founder mutations that we found in more and more population that we simply have more data and we can now identify them. There's a plethora of mutations that are being found today by medical geneticists and non-medical geneticists, which we simply can't keep the primers and the knowledge. It is hard enough to keep track of which mutations are being identified in Israel every week, not to say to have the ability to screen for them. Many patients at our status are going pregnancy that we would like to have something which is rapid and robust to allow that we will have a very fast answer for a very large number of mutations. And there are more and more sperm and egg donors in Israel coming from Europe, and the mutations that are common in these regions of the world are simply not covered by the Israeli panel. Last is that there are quite a few clerical mistakes about the origin or residency of the individuals. So what we are going to try to do is we are not going to discuss NIPT, but we are going to try to say whether it is possible for us to merge expanded carrier screening and chromosomal microarray analysis using the array technology. So array technology used for chromosomal for CMA is primarily being divided today into array CGH and SNP arrays. Both of them have the ability to measure intensity. I'm not going to go into the details of the technology, but I would like to mention that the SNP arrays are measuring one more thing, which is the zygosity bar. It means that a SNP array, the probes that are attached to it, can say if in the given position which is being tested, there is a C or T, not only an intensity signal, also to actually recognize the chemical base which is there. This is the concept of B-allelic frequency which is being used for a diagnosis of CMA. If you will look here, each dot represents one SNP. Each SNP is represented by dozens of probes on the array. It's like the concept of coverage in NGS, exactly the same. And the minor allele frequency of each SNP is known. We know it from the literature. So that means that in a normal population, if you're going to check a region which has like 1,000 SNPs, then you will expect that some of the SNPs will have in their AA form, it can be AA, CC, TT, or GG. AA just stands here for an A, not for adenosine. Some of them will be in the heterozygote state, like C to T, and some of them will be in TT. It will be the minor allele frequency. Now, we are not going to go through this, but this is a histogram which is indeed being created by the machine every time you're using an array. If you have 700,000 SNPs embedded on the array, the analytic software will indeed create 700,000 histograms of this type, and they will be able to decipher the CCs, the CT, and the TT. Now, you can start playing with this. So you can start with an array customization that has a huge capacity. You can do 2,800 samples per week easily. And you can start looking first if you can use it to do CMA. So here is a classic presentation of a microdeletion using a SNP array. So you start with a SNP array. This one is Illumina Omni Express. It has roughly 730,000 SNPs on it embedded. This is the karyotype. That is the representation of a microdeletion in this karyotype. You can see here the intensity bar, which is lower than the standard 0. And you can see here a region of loss of heterozygosity because there is only one copy in the DNA, and accordingly, theoretically, you cannot have a C to T. You can have only CC, TT, AA, and GG. Of course, you have CAG, but the machine reads it as a CC. But the most important thing about this figure is not the fact that this can be done. The important thing is this word, SNP. We are not allowed to use the word SNP anymore because it contains the word polymorphism. And polymorphism have different meaning by different people, so we are being encouraged to use the word SNV, single nucleotide variant, and then try to say about the variant what is its pathogenic or non-pathogenic effect, and so on. That is the recommendation of the AGV. So if we think about SNVs, for example, it is something that we have to remember that variants that affect function, also known as mutations, are in many cases single nucleotide changes, just a C to T, or can described by designs make them look like ones if they are large deletions. So that means that actually, if we want to screen for mutations like in the cystic fibrosis genes, we are actually treating with variants that are behaving exactly like the polymorphisms, so to say, which are being embedded on the array for the CMA. The only difference is that the embedded SNPs will be in a high frequency in the population, which means that you expect that 30% of the individuals will be heterozygotes, let's say. But the mutations, of course, will be very rare. So we can start embedding on the array, adding to a basic content, mutations. Here is an example of a CFTR mutations that you are all familiar with. It is a 3846G2A in the CFTR gene. You can see here the normal. So in this particular run, there are 285 normal individuals. There are 4 carriers, and there is 1 affected. And you can also do on the array something important. You can embed assays on the forward strand, on the 5 to 3, and on the reverse one. And therefore, you can have an extra confirmation that indeed you found your finding was accurate. So now that you can see that we can customize our array, we can start thinking, okay, which will be the added content that we want to add? Can we add autosomal recessive affected states? Would you like to know if your patient is affected from CF during pregnancy? Maybe. I'm not saying that we should do it, but I'm saying that it might be possible. Would you like to check recurrent hotspots during CMA? Would you like in the week of 16 to 18, or in maybe even earlier in CVS, would you like to identify achondroplasia? Or maybe the severe form, thanatophoric dysplasia? Or maybe you would like to screen for Duchenne muscular dystrophy. So these are content that can be added. So a question that can be answered, for example, we are using chromosomal microarray analysis. Can we enrich the DMD gene to detect a carrier state of Duchenne myopathy? So we did it, and indeed that is possible to do. We are doing it in a very routinely day now. You can see here, this is a female. The DMD gene, which is a very long one, 12 megabases, was enriched by a few thousand SNPs. And you can see that you can clearly identify here a deletions of a few exons. Naturally, we are taking advantage of the fact that we know that Duchenne myopathy in 66% is being transmitted from the mother, and then in 66% it is due to a large microdeletion or microduplication rather than for a point mutation, which is the remaining third. We can also identify a duplication in the Duchenne, in the DMD gene. So we can offer this test as part of a preconception screening, expanded one, without any additional cost, for example, for the people that are taking the panel. So let's think about the categories that we can add. So we can add preconception, cystic fibrosis. We can add prenatal mutations like CMA, like thanatophoric dysplasia. We can even put on the array mutations that are usually being offered as postnatal, familial Mediterranean fever. And we can also include oncogenetic mutations like the BRCA1 mutations. Naturally, that might be an ethical nightmare to check all of these mutations simultaneously in a preconception stage or for an embryo. So we have to find a way to harness from the array its benefits while blocking the dangers. So we must recognize that it will be much cheaper to do everything on one array that will reduce costs, and that is a very important issue in medicine nowadays. But we cannot endanger our patients with ethical or other issues. The point here is, why do we want to achieve such things? Because really, parents that are coming to use such an expanded array at the preconception stage can use their data to clarify a variant of unknown significance identified in a CMA of their embryo. In some cases, a CMA is being performed on amniotic fluid, and there is a variant which is unknown if it is benign or pathogenic, and many times the treating physician will be ordering the CMA of the parents to see if it exists in the parent or not, which will add some points to its being a benign or pathogenic variant. So you can save these costs from the couple. So how to analyze so we don't make damage? We can simply not call irrelevant data. We can call but not interpret irrelevant data. And we can analyze but not report. So I think that we all feel very uncomfortable with analyze but not reporting because we know it, so that's not a real option. And we don't want to not to call irrelevant data because then the couple will have to pay again for the CMA maybe. So we want to call but not interpret irrelevant data. And we should go through the process. So in order for one to establish the data, he needs DNA, he needs the array, and he needs the machine. And there's a need for a DMP file, which is array-specific encoded file supplied by, this case, by Illumina. So that is really being a file being supplied under a secured website from Illumina, which is specific for this particular slide. Then when you run it, you are creating the IDETS file, and this is what you see. So remember, when you run your DNA on the slide, the DNA will not know to which probe to attach or not. It will attach to all probes. But the output is this IDETS file, which represents all the places in which the fluorescent read the array. Now, I am sure that none of you can read from this that Mr. Smith has a BRCA mutation because this position seems to you to be a pathogenic representation. So in order for somebody to be able to do it, he will have to break into the laboratory that did this test. He will have to steal the slide. He will have to go to a different lab. He will have to break into the website of Illumina. He will have to download again the DMP file. Then he will be able to know if this individual has a BRCA1 or BRCA2 mutation, which puts us in a relatively safe situation. So we can be in this situation, and then we need to use a sample sheet, which is just saying which individual is where on the platform, a BMP file, which is an encrypted file listing the variants to be analyzed from the images, and an EGT file, which encrypts the file needed to create the clusters and the histograms. So we can choose different BMP files and different EGT files to read only the mutations that we want to read in this particular scan of the machine. We can keep the IDETs in an archive and rerun them using different BMP and EGT files to answer other questions. Okay. Then we can interpret and create results. So the content of the panel is now, for example, in this one is having over 250 homing phenotypes, which represents something like 1,000 mutations. It has multiple genes that we are testing, like the DMD, like the CFTR gene, and so on. It has the ability to do CMA, and it's very, very robust. A little bit numbers before I'm being kicked away. So you know that the carrier rates that can be found in such a panel is roughly 40%. Severe diseases is 1 to 5. Second class 2 diseases is 1 to 12. Group 3, like deafness, is 1 to 9. There are 6%, or a bit more than 6%, that will be carriers for more than 2 diseases. The standard screening panel will reveal 51%, and the expanded will reveal 49% of the total mutations. And the rate of couple at risk will reach 6.3. With this, I will not tell you a bit more clinical data. I will only go to the advantages of the arrays. So they are not explorative. You know exactly what you have embedded on them. There are no VUSs. There are no incidental findings. You can create uniform panels. You can periodically update them. And you can work tightly with healthcare providers to answer their regulatory requests. It's a massive technology that can do thousands of samples using one machine per week. It can streamline a few lab processes. It is robust, higher throughput, and very importantly, chips are cheap. This is the last slide. So our messages is that preconception practices should be revised to fit the genomic and information eras. Expanded preconception and prenatal screening are facts. Regulatory agencies should suggest clear guidance now, or it's going to be the Wild West, and universal couple screening should be considered. Thank you very much for listening.
Thank you very much for this very interesting presentation of new technology. Technology is important for screening as well as development. The next speaker is Neta Zach from Teva.